Hello, hello, and welcome to the weekly live that we'll be doing every single week here. Whether you're joining me on LinkedIn, Facebook, or on YouTube, welcome. I am happy to have you. Today, we're going to go over the 5 things absolutely everyone in dentistry needs to know about the game changing impact of myofunctional therapy. Now, myofunctional therapy might be one way that you've heard this term. There's actually a couple of different ways that it has been referenced. And so let's talk about it. So let's figure out between oral facial myofunctional therapy, oral myofunctional therapy, and those last two, typically when people are talking about myo, they might reference it instead of using MYO as the abbreviation, they might reference it as OMT. So those two are the ones that you may have gotten that OMT reference from, and then just plain old basic myofunctional therapy. I will say that oftentimes, sometimes it's confused whether it's by a professional or by a layperson, but myofunctional therapy is not myofascial release. It's not myofascial therapy. Those are two different things. That's manual therapy, manual manipulation with the hands. And so we don't want to confuse those two at all. But actually, all of those names mean the exact same thing. So whether it's oral facial myology, you've heard oral facial myofunctional therapy, oral myofunctional therapy, or whatever people are deciding to call it tomorrow, it all means the exact same thing. Okay. So it's just a profession by many different names that honestly has very little in it that's standardized across the board. So there's going to be a lot of times where you'll have that hold up. I'm confused. Like, what are we talking about thing going on right now? And that's okay. It happens. Myofunctional therapy is most likely what you may hear most commonly. It is actually the most Googled term. So when it comes down to the defining of an official correct term, I'm always going to say that it's myofunctional therapy. So, one, more commonly than anything else, myofunctional therapy wins hands down on any sort of Google research, like keyword SEO topic. Flat out. So the general public knows it as myofunctional therapy. I think we need to start referencing it as that too, because it actually originated in dentistry. So if you didn't know that, welcome. Over 100 years ago, the man in this picture here, who some of you may know and others of you may not, Dr. Edward Engel, he had a very prominent student, Dr. Alfred Rogers, who actually went on to being very, very prominent and was the leader of the New York Orthodontic Society and taught at Forsyth. And he had a lot of big prominence in the orthodontic field in the early days of orthodontists. So, Dr. Alfred Rogers actually did a lot of early research with Edward Engel to help kind of discover what's going on with this whole myofunctional therapy, with this whole malocclusion thing. Because Edward Engel, as you may know, is the father of malocclusion, right? And some people term him one of the fathers of orthodontics. Everything has kind of shifted from where we all started. So we started with this concern with why are we developing malocclusion? Why exactly do we have some people who have teeth that come in wonderful alignment and then others who just don't? Well, early orthodontics really advocated for getting to the source and achieving facial aesthetics. So we want facial symmetry. We want everything to look really good. How are we going to get that to happen? Well, we can only get that to happen actually if we deal with the soft tissues. So Alfred Rogers' research in the early 1900s, because by 1918 he had over 50 articles published about this, really led to the determination that myofunctional therapy, which was later the term for it, but the soft tissue and the manipulation of the soft tissue really does determine the position and the structure of that hard tissue. So craniofacial development is highly dependent upon the soft tissues. Okay. So, around the mid 20th century, we kind of started to change. Everything changed and shift over in this field. And we introduced new professionals. So, speech language pathologists were brought into the profession, and orthodontics just decided it was going in an entirely different direction than where it began. So, early on, Edward Engel had really advocated significantly so for the advancement of facial aesthetics, myofunctional therapy, and the concept of dealing with these soft tissues that are really going to create that stability. However, around the mid 20th century, when everything was changing and things were shifting, orthodontics really leaned back into occlusion. How do the teeth come together? We want them to come together for class one normal occlusion, not class one malocclusion, class one normal occlusion. And so the focus really began with that mid 20th century shift into okay, maybe we don't want to focus as much on aesthetics when we could just extract and get everything into a nice order and then make the teeth more pleasing aesthetically instead of having to do a lot of work to expand and to chain and to bring things down and to manipulate and to have myofunctional therapists on board. So it's kind of like shortcutting, and we don't like shortcuts. As an evidence-based field and profession, dentistry does not like shortcuts. We actually do like things to go nice and smooth and to have long lasting effects. Well, it turns out that some of those long lasting effects of all that extraction and retraction did turn out in the adverse way that we wanted, and that we're having a lot of people who have issues with sleep, with breathing, with digestion, and so forth from having more narrowness in that oral cavity. So, let's get into narrowness of the oral cavity. How do we even get there? We know at this point in time where your tongue rests matters. If you have never heard me lecture about anything, I always try to find a way to put this slide in some way, shape, or form. So you've probably seen it. If you've heard me lecture before, if this is your first time hearing me lecture, welcome. You're going to see this slide almost every single time. Where your tongue rests matters. When the tongue is at rest, we want that tongue to be lightly suctioned up from the incisive papilla all the way back to the soft palate. So lightly suctioned. So you can imagine that suction between the tongue and the palate. And you may see pictures of me like that, right? That suction. And that's happening when we are not using our tongues. So anytime that we are not speaking, eating, drinking, our tongue should be suctioned up against the roof of the mouth. What's that going to do? That's going to apply a light constant pressure. That light constant pressure is actually going to help manipulate that palate. And so it's serving almost as a scaffold and creating a blueprint for how that palate should grow, how wide and how broad that palate should go. But when it's not suctioned up there, we're going to get different types of alterations and variations. And this is over a century of research. Okay. So there's a lot behind this. Now, when we're looking at our image here, image one, we have 42 millimeters of intermolar width. So intermolar between 2 and 16. Okay. So you're looking at 2 and 15. Sorry. You're looking at these two teeth and you're going in between and you're saying, okay, 42 millimeters. That's pretty big. Most of the time when I go into my patient's mouth, I'm seeing it much, much more narrow than that. I don't think that I could even get a cotton roll in between there. And the cotton rolls on average between 37, 38 millimeters. So if you can't get a cotton roll to fit comfortably in between your patient's molars, you know that you're not at that ideal width, right? So where might they be instead? Well, when that tongue is up, because a lot of people will tell you, my tongue is up all the time, but they have this narrow arch. Well, if their tongue is up, but it's only lightly suctioned up, and perhaps maybe the tongue tip is up, but the rest of the body of the tongue is down, so it's more angled like that, you're going to wind up having a little bit more space in your arch in the front, and it might develop more like an omega shape, right? So then you'll be more narrow at the intermolar width space where you're looking at like 37. You might fit that cotton roll really in there, but your wisdom teeth may be more crowded. Then you have image three, where we're looking at a 30 millimeter, which is like if you're 8 years old, that's wonderful, 30 millimeters. But outside of that, you really need much more width in between. And these are the people who say that their tongues are too big for their mouths. Well, we know that that's not true. It's actually that their mouths are too small and that the tongue hasn't been sitting where it needs to sit. So If the tongue is sitting in between the teeth, that's going to create now a soft tissue pressure that's lightly pushing in on the teeth. So, whether it's sitting against the teeth and creating like scalloping or an open bite, or it's sitting all the way in between where you really have a prominent overbite, and you're not able to close those bites with your orthodontic treatment, or you're struggling to get that retention as you are trying to close it with orthodontic treatment. More often than not, it's that constant light pressure. I know a lot of people like to think that it is because of the tongue thrust. So it could be that anterior thrust or that lateral posterior thrust. And you're thinking that every time you swallow, you're creating that. It's actually the light pressure of every time you're not speaking, eating, or drinking, that tongue sitting up against there that's creating that. Then we look at number 5. If we think that at the roof, we're now going to create a light pressure that's going to grow the palate. And at the teeth, we're going to create a light pressure that's going to impact how those teeth are able to occlude. Well, if the tongue is low and all the way down, of course it's going to develop the mandible, right? So that's when we develop more of those class 3. So this is a really great foundational concept about how your tongue rests, and how that really matters overall to your development. Now, once all of these things are set, okay, it's very difficult to change. Myofunctional therapy, a lot of people mistake it as like natural palatal expansion. You would have to intervene very, very early for it to provide the kind of long term effects that you want it to provide. If you are meeting somebody and they are around 7 or older, you're probably going to get, with just myofunctional therapy alone, 2 to 3 millimeters of intermolar width. But that 2 to 3 millimeters, imagine healthy perio pocket, okay? It's really not a lot. It's not significant at all. So, what are our goals with myofunctional therapy? Are really true goals, because we're not looking for palatal expansion. Honestly, that's a happy accident. I'm not looking to help you with anything else other than proper oral resting posture. And that needs to be the foundation. That needs to be the thing. If we are talking about anything else, it's a happy accident. Myofunctional therapists are completely out of scope if they're talking about being able to do, magical things with your sleep, or to help with this, that, and the other thing. We are really, really skilled and educated in enhancing proper oral resting posture, achieving proper oral resting posture, habituating proper oral rest posture, or however you would like to phrase that. But all the other stuff is a happy accident. These are other people's medical fields. These are other things that happen as a result of that may correlate with having proper oral resting posture, but absolutely not things that we're going for. So, what exactly is proper oral resting posture? That's having our tongue up, so the tongue suctioned up against the palate from that incisive papilla all the way back to the soft palate, our lips closed, and predominantly nasal breathing. Outside of that, everything else, happy accident. Okay. So I'm going to ask you to 100%, if you've never thought about it and you are not talking about this with your patients in the office at all, you need to. Don't ignore the elephant in the mouth. Okay. Our tongues are actually more like elephant trunks, or like octopus tentacles, where they operate in a hydrostatic way. So it's a muscular hydrostat. So what's going to happen? Imagine like hydraulics, okay, on a car, and what makes it bounce and how the gears all have to work together in order to get that to happen. What's going to happen with our tongue is that all of the 8 muscles, so 8 in half, so there's really 16 that have to work together and collaborate in order to create all the different shapes and all the different manipulations that we can do with our tongue that we can't do with other muscular organs. Okay, so we can't make everything curl and loop and twist on itself and up and down and suction. We can't make everything in our bodies like that. We can make our tongues work like that. So it's an incredibly powerful muscular organ. I like to call it a respiratory organ, but it's incredibly powerful muscular organ that if we ignore it, if we ignore its position, if we ignore what it's impacting in the oral cavity, we're missing a lot. We're missing a lot for cavities. We're missing a lot for our patients and those, especially with dry mouth and their salivary content. We're missing a lot for digestion and gut health. We're missing a lot for perio. You're missing a lot overall. Okay. All of your hyperactive gag, your super sensory patients who have issues with sensory processing, you're missing a lot if you ignore that wonderful muscular hydrostat that lays right dead center in your work area. So please, I'm going to implore you, if you do nothing else, just start paying more attention to the tongues. Don't ignore the elephant in the mouth. Okay. I think that's probably the best slide. If you want to leave now, leave now. But there's a lot more, I promise. Myo likes to help. Myo is very helpful when you are mad, MAD. Now, I like this analogy because when you're mad, you're most likely with the M's, mouth breathing, or you're in malocclusion. You're asthmatic, allergic, or anxious. That would be your A, or you're generally muscular dysfunctional. So you have some sort of oral facial muscular dysfunction, okay, or an OMD, as we would call that. There are a lot of acronyms throughout this field. Don't try to memorize them all. This is just a really good one. It helps MAD, mouth breathing, maloccluding, asthmatic, allergic, anxious, and dysfunctional. Some of these pictures that you'll see here, you might recognize in some of your patients, particularly the flaccid lower lip. The people who come in looking like the guy from that movie. Oh my gosh! Now it literally was just here, but John Heater's character, and he's just very lax with that lip. Flaccid cheeks are also a thing. You'll see the child there with the full cheeks. You ever meet one of those children and you really just want to go up and just pinch their cheeks? You're, oh my gosh, these chubby cheeks, you're so cute. Don't pinch those cheeks, actually. Those are not maturely developed cheeks. You really want to send them to a myofunctional therapist because I guarantee you they are going through something, whether it is improper salivary management, so they might be droolers or they might be very messy eaters. There's difficulty with them suctioning or drinking properly or appropriately. I'm guaranteeing you, those cute, chubby cheek kids, they've got stuff going on. Mentalis strain, you'll see a lot and often too. That mentalis muscle can, when it's overdeveloped, very much look like the dimpling that you would see on an orange peel. Tongue tie we'll get into in just a second. Allergic shiners are a big one underneath the eyes, that darkness underneath the eyes where blood vessels pool and it's a lack of oxygenation there too, so you're seeing it a bit more prominently. Cupid's bow, where the lip actually looks like a cupid's bow, so it's kind of tipped up like that. So you imagine if you have a bow and arrow and how that would look, where the lips almost carry that same shape as well. Okay, so myofunctional therapy incredibly helpful, and you'll be able to look at people at a certain point in time in your life and you will note it right away. So let's get into the 5 things that I want everybody to know about this myofunctional therapy thing. Number 1, we just talked about tongue ties very lightly. Myofunctional therapy is essential for the tongue tied. Really great book by Richard Baxter here. It's been out since 2018. This discusses in length the history of tongue ties, the associated signs and symptoms, and all the interdisciplinary specialties. So whether you're working with babies and you're talking about lactation or feeding consultants, or you're talking about all those things, or you're talking about older populations and adults, and you want to talk about myofunctional therapy, and you want to talk about manipulation, so manual therapy, body work. I try not to call it body work, manual manipulation. These are all discussed in this book, along with the procedures and lasers, and then the difference between laser and scalpel, and all sorts of things. It's over 300 pages about tongue tie. Now, let me tell you, I am in the field, very much in the field. I am all about it, and I understand exactly. I have not read this whole book, so I do not judge anybody who has not read this whole book. Over 300 pages of tongue tie is a lot of information, and not a soul I've ever met in life has been that interested to read it from front to back. But it's got great information, so it's definitely a great skim, if nothing else. Okay, so the big question that's going to come up is tongue ties, but it's really just a fad, right? Or it's just like a trend. Actually, it's not. Some of these articles, it's been very popular in the media. It comes up again and again. If you just heard about the New York Times article, this is like them coming back for the third or the fourth time writing about it. So, New York Times had an article that came out earlier this month. I want to say it was a couple weeks ago, right? And that came out discussing the booming business of babies' tongues and how dentists are profiting greatly over doing this procedure that is completely unnecessary and unsubstantiated. I'm going to tell you, I'm going to tell you what not a lot of people are going to tell you about this article because I had a really great conversation this morning about it. Pardon me one second. This is the benefit of live, right? Got something stuck in my throat. Okay. I'm going to tell you something that I think about this article that's very controversial. Okay, so here you go. You get a little bit of controversy for your day. Some of these articles are from as far back as 2016, 2015. People are writing about this. It's been an international, the Daily Telegraph, HuffPost, these are international um, outlets that are reporting on these things. When they report on it, they always report that there's not a lot of research. And I'll tell you that some of the best research articles that have been done about tongue tie procedure and its efficacy in being able to facilitate and help with other things have been done on a couple of hundred people. So we're talking about 300 to 400 people, really exceptional, great research. But in a population where just in America alone, we are over 300 million people, and in the world globally, we're 8 billion. 300 people is completely insignificant. I can throw that away with any sort of relevant scientific, knowledge. So they're not doing bad journalism. And I think a lot of people want to write it off as bad journalism and say, well, people aren't going to get help if they listen to these articles. I think people, if they read between the lines and if we get better as a profession at educating people on why they're getting the procedure, a tongue tie release is nothing more than a surgical cosmetic release. That's it. We are taking away, removing, or otherwise altering a piece of tissue in the mouth. That does not impact function. Stop telling people that that's what it does. Stop telling people they just have to do this simple little thing, and then once they do that simple little thing, that's it. Okay? That's not it. Before they even go in, they need to work with a functional provider. So if it's a baby, they really need to have a feeding specialist or a lactation consultant working with them before they're even considered. And I mean working with them, not looking in the mouth saying, yep, there's a tie, go get it released, and then we'll work together. No, 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 no. They need to work together before. And the same thing for older populations. You have to work with somebody before. That way we can see where the function is at. And if the function can be remediated without having the release, then once we've determined that no, we need the release based on we can't meet these functional metrics of such, 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 and such, awesome. Now we do the release and we get back into work on the function. These are the conversations that we really need to be having in order for us to get this narrative to stop, that it's a fad, it's a trend, and it's something that's just making money in dentistry, that it is actually something that is beneficial, which is going to lead me to this whole rabbit hole of what exactly, well, what's a tie then? And how are we supposed to determine whether somebody needs to be released in office? You can't determine that in office because guess what? I don't care what the lip looks like. I don't care what the tongue looks like. It's not a tie unless there is a lack of function. You have to have a functional purpose for a release. Okay. And yes, yes, you heard me correctly. I'm not, I don't joke around with this topic at all. It is absolutely something where you have to prioritize how it is functioning over what you may have feel, seen, or observed in your chair. Okay, so Myo is essential. That's our tip number 5 for the tongue tied. Okay. So let's imagine, I love this image here because you look at this lady's arm. It looks like one of her arms is tethered to her body and the other arm is nice and free. And let's say I'm going to make her 25. Okay. Let's say for 25 years of her life, she's always had this right arm be able to move freely and the left arm not so much. And she's never felt any sort of um, disability as a result of it. But somebody comes along and says, "Hey, your arm is tethered to your body. Did you know that your right and left arm should both be able to raise up in the sky like this? Like you should be able to do this. You never thought about doing that before?" She's like, "Oh, well, no, I don't think I have. I guess it might be helpful. Awesome. Let's do the release." Okay. And they release the tissue in between that left arm and her torso. Well, what's going to happen at that point in time? Do you think her biceps and her triceps are going to be strong enough to facilitate her being able to elevate this arm, to be able to even lift it up to the side, much less be able to lift it up her trapezius? Like, how is she going to be able to functionally use this arm? It's not going to do that, right? And all the PT in the world isn't going to help her get full range of motion afterwards. You know why? Because without doing any prep beforehand, those muscles are not prepared for the capacity of which she was going to need to have in order to achieve optimal range. So when she's healing back down, it's going to heal back down in a way that is going to be more restrictive than if she did work beforehand. So myofunctional therapy is really just like working all of those muscles in the tongue to get them and to facilitate them moving and strengthening and engaging and improving your range, improving the isolation of the tongue, because a lot of compensation where you have your jaw moving with your tongue or your jaw carrying your tongue or you're using your lip to facilitate different motions for your tongue. We're eliminating all of that and enabling you to strengthen your tongue and your mobility of such, your range of such prior to a release. That way you heal better after. You heal better after. So I've got a really great video on that, on what poor healing looks like and why. Ask me about it if you're very interested. Hit me up in the replays. Let me know right now, actually, in the comments, does this make sense? Okay, because I'm certain it does. Let's go on to number 4. Mayo is not just tongue tie. So 5 was it's great for tongue ties. 4, we do so much more. We do so much more. Mayo has a lot of wonderful happy accidents. We are able to help people who are suffering with TMD, who have mouth breathing, who have habits that they need to get rid of, tongue sucking, thumb sucking, nail biting, cheek biting, all sorts of oral habits that are negative in nature. We are able to help facilitate those parafunctional habits, such as the bruxism. That's absolutely something that myofunctional therapy is able to help with. Sleep-related breathing disorders, CPAP, and oral appliance tolerance, and the list goes on and on and on. You heard me talk about perio and gut health and digestive issues and so forth. There's so many things that we're able to help with. So it's not just limited to tongue tie. Don't think that the only people you can send to a myofunctional therapist are those that have tongue ties. Okay. So let's look at some of the research that exists for some of this other stuff. So we talked about TMD. In this one particular study, they determined, and it's very eloquently stated and written, that myofunctional therapy aims at equilibrium of the functions according to the occlusal condition and to the condition of the temporomandibular joint itself. And the subjects who follow the therapy program learn to control their movements and to avoid joint clicking and pain without negative compensations, and start to recognize the factors triggering the symptoms and to avoid and or control them, as all the procedures regarding the objectives related to temporomandibular disorder and the way to carry them out are explained to them during therapy. It's a very educational process where they're learning how to create new neuromuscular patterns that they don't even realize they're creating, but they're understanding how some of their compensatory patterns were actually contributing to the degradation of the temporomandibular joint or to exacerbating the pain or the parafunctional habit that they were currently experiencing. So it's actually really, really helpful. That was such an eloquent way to put that. Helping with pediatric sleep disorder breathing and mouth breathing. This one study determined that there were differences reported through those undergoing myo compared to those who did not. All 3 measures of apnea-hypopnea index, so their apneic events where they stopped breathing, Their O2 saturation, how much oxygen did they have, and the nasal flow limitation, so how much resistance of air intake through the nose, showed improvement in the myofunctional therapy group. So we were able to achieve a lot of improvement with oxygen saturation, our ability to nasal breathe, and the apnea hypopnea index. It's really, really a wonderful, like game changing treatment. Wonderful happy accidents. Okay. Myofunctional therapy for sleep disordered breathing. Let's continue on. Myofunctional therapy revolves around the principle of improving a function through repetition, metacognition, and awareness. For example, the tongue is repositioned and trained to contact the palate comfortably, thus providing the natural negative pressure, light suction from the incisive papilla all the way back to the soft palate that keeps the tongue and especially the genioglossus in the proper position during sleep. The genioglossus, it just gets me so excited, right? The genioglossus is such a big muscle. It is important in keeping that tongue up and out of the airway. It's actually the one that's predominantly responsible. When you have a mandibular advancement device, guess what muscle you're moving forward? Your genioglossus, and it's certain when you're moving a lot, but your genioglossus for sure, because that genioglossus inserts from the mandible and it helps to carry the back of the tongue body up towards that palate. So it lifts it up. And that's what we want. We want to keep that tongue up and out of the airway because when we think about snoring, what is the sound of snoring? No, it's not adorable. And yes, it's annoying, but it's not just annoying. It's actually the sound of air meeting resistance as it's going through your upper respiratory tract. That is air meeting resistance as it's going through your upper respiratory tract. So air is trying to enter your body, our essential life force. You can go for days without water, weeks without food, but not many of us can go for more than a few minutes without air. Okay. We need it. It's an essential life force and it is struggling to enter your body as it is reaching through these tiny airways. And as it's passing through, it's causing vibration of the tissue because it's forcefully trying to get down your tract, your upper respiratory tract. Okay. So snoring, it's annoying, but it's also deadly. Snoring, it's not cute. It's just deadly. Nobody would want to meet resistance with food. Food also goes down this same tract, right? You would hate it if every time you tried to eat, you were trying to get food down and it just would not go down. So, why do we accept that every night we struggle to get air into our body? Hmm. Let's think about that, right? So Myo is not just for the tongue-tied, it's also for those with CPAPs. This one study was really good at showing that, where there was determined and showed improvement in tongue and soft palate muscle strength when compared to the placebo group. The association of Myo to CPAP showed an increased adherence to CPAP. CPAP has a 30% compliance rate. I think somebody told me it was 40% at this time. Like they went up 10%. Yay. That means instead of like 8 people using it, like 10 people use it now. It's not a lot. The compliance rate is still terrible for this thing. So, our CPAP group actually is going to show that there is improvement in them being able to wear and sustain the thing because now they have better control over their musculature. So, having better control over the musculature is going to help you to be able to wear this thing over your mouth, over your nose, and to have it comfortably in play. Okay. Orthodontic treatment, myofunctional therapy is a valid support to the orthodontic treatment in cases with functional bad habits, all those things that we help to eliminate, and can lead to very good therapeutic results, i.e., read attention. Okay, retention, sorry. Reading retention in that spot there, I think is the most important thing. A lot of times we want to look at the retainers that are in the mouth or the removable ones and like, oh, you have to wear this forever, otherwise everything's going to shift. What's very interesting is that the only thing that causes the teeth to shift is those pressures of the soft tissue, right? Or when you have the periodontium, where your bone is not able to maintain the teeth in a stable position. So let's take perio out of the case. Let's take a lot of bone loss out of the case and all that soft tissue. If you have very good consistent pressures that are countering each other, so you can create a stabilizing pressure between the lips, the cheeks, and the tongue. So you have pressure on both sides of those teeth, and it is a great counter pressure that's going to stop any sort of movement anyway. So retention is what you're really going to get out of orthodontic treatment. Myo is a selfish referral. Number three. Okay, so we're going to move on from all the wonderful things that Myo helps with outside of tongue tie. It's a very selfish referral for any dental professional. If you are referring to a myofunctional therapist, you are operating at your highest ethical standard, number one. Number two, you're operating at a higher personal standard. Okay. So your personal standard has risen because anybody that you know in your chair that's a mouth breather that you know has poor orthodontic tension, a poor orthodontic retention. I don't know why I don't want to say that word today. Apparently, I just want to say attention, but poor orthodontic retention, poor gum health, gingival stability is not there. Their periodontium is wrecked. They've got vertical bony defects that absolutely they have issues that you know are going to cause to further degradation of that bone, our dry mouth, bruxism, or digestive issues. You're referring them because it helps you. Okay, you're referring them because it helps you do your job better, and by secondary effect, it's also going to help the patient. We do want to help the patients, absolutely. That should be, yes, the primary goal, but it is also very selfish because it does help us. For me as a dental hygienist, it helps me. That way, I don't have to work as hard on them when we do our perio maintenance. A lot of people you might have come back after you've done all the oral health instructions in the world. If they have parafunctional habits, I don't care what kind of mouth guard you put into their mouth. I don't care what kind of instructions you tell them about stress and stress management. If you have not actually gotten that under control, you are going to have a chronic perio situation and case on your hand because all of the biomechanical factors, so the impact of those forces, we know that our occlusion places a lot of heavy impact on their teeth themselves. So 70 to 80 square pounds of pressure as we're just masticating. Imagine you don't need to even masticate. You're just bruxing or clenching throughout the day, putting those same pounds of pressure continuously and creating that force that is creating those vertical bony defects. And then on top of that, you're a mouth breather. Now you're allowing anaerobic bacteria an opportunity to sit in a space where they're going to be safe because they've got that nice vertical bony space, all of that gap in between the gingiva and the bone. And so they can sit right there and cuddle in nice. They're creating such a wonderful environment for me. And I don't care how much you scale it. I don't care how often you do SRP. I don't care if you send them to the periodontist. If they're continuing with those biomechanical habits because you have done nothing about it, you're creating more stress, more strife for yourself because you're going to keep talking to them about all these oral health aids and all these adjunctive things you can do for them. And if you're not creating stability, you're just continuing to create more work for yourself. And we are a profession of prevention. So if we're really going to prevent, we need to address the totality of all the reasons that that's occurring. So whether it be just the biochemistry, where that's all of your bacterial infection, oral hygiene, yada yada, we need to also look at the biomechanics that are a part of that. Okay. So when we are looking at all of that, it's helping us with our perio. It's helping us with our restorative work. That is less work that you have to do as far as caries, decay, crowns, and so forth. And you are more likely to get them into those conversations about having clear aligners or being able to do treatment for orthodontics if they are understanding the full totality of all the factors involved. It's not just clear aligners for aesthetics, it's clear aligners for your periodontal health. It's being able to facilitate a space where your tongue can rest in harmony and you can create those soft tissue pressures that give you that stability and so forth. Okay. So it's a very selfish referral. Um, with myofunctional therapy, you're going to find a lot of things that happen and improve in your professional career because you're helping people at a greater level. So you're impacting your patients in a more unique and lasting way. And I will tell you 100% hands down, we already know that 80% of our patient population, 80% of America, okay, because you and I are a part of that too. 80% are going to Google, it's a verb, okay? It's a business and a verb, are going to Google before they go into any of their healthcare practices. If they have something going on, they're going there first. And a lot of people are discovering myofunctional therapy. A lot of people are discovering more alternative, holistic, or natural solutions for things that are going on. And that's what's in demand. There was a study done in 2022 by the National Institute of Health, and they are absolutely stating that in this survey of tens of thousands of people, one out of every three want to see in their practices. So when they are seeking medical and dental practitioners, they want to see alternative health as an option within the practice. And if you're not doing that, you're winding up being behind the ball, far behind the ball. And dentistry, in a lot of different ways, is already pretty outdated, but it's time for us to move into this next phase and this next step. If you want Gen Z to get into your office, if you want to really like push your practice as far as organic search and marketing and being able to sustain your team, being able to sustain your practice in order to increase your revenue, you want to keep and maintain as many patients as possible, you've got to start thinking about myofunctional therapy. There is absolutely nothing more selfish than myofunctional therapy in your practice. And as a byproduct of that selfishness, you're going to be impacting the lives of so many more, not just in your community, but within house, within that practice. Okay, so let's talk about that. So we'll talk about my story for just a second. So I am a mom of four. Yes, I have four children and they all think I'm 21. Don't tell them any different. Okay. My son, he's my oldest and the only boy, so he's been very disappointed every time I've gotten pregnant since. He had a lot of issues with attention, emotional regulation, impulse control, and was struggling for a long time in school. We actually had that conversation for the first time with his kindergarten teacher who said that he really just could not ever pay attention. He would take one of those sun fuzzies, the little dust that comes in from the rays of the sun through a window. He would take one of those and would watch it meticulously and would not take his eye off of it as it floated down and around in all sorts of ways, but he could not pay attention during story time. It was always something else that he would be focused on. And I'm like, but he's 5. He's 5. What does a 5-year-old want to do with a structured school setting? Nothing, right? The teacher, she's just dramatic. And we played that game. I was like, oh, he's 6 to the first grade teacher when she's telling me something's wrong, and the second grade teacher and the third grade teacher, and he's 7, but he's 8, but he's 9, until it stopped being a game we could play and we had to actually address it and see a pediatric neurologist at some point. And at that point, she asked us a couple of questions from a questionnaire, and boom, that was it. Diagnosed with ADHD, and he was on medications for almost 2 years. And we went through 3 different types of medications, and every single day he was medicated, and it really didn't help much at all. We'll get back to that in just a second. My oldest daughter, very big thumb sucker, and she had every sleep issue under the sun. I mean, you name it, we were guaranteed for the first 10 years of her life, every single night straight. Didn't matter what we did, didn't matter how long before bed, we didn't give her something to drink. Like, she was going to wet the bed every single night. And then that was accompanied by a lot of other different things. So whether she was sleepwalking or she had night terrors or she was tossing and turning out of the bed, falling out of the bed, everything. At some point, we addressed it with the pediatrician. The pediatrician said, well, she won't be 15 and doing that. She'll definitely grow out of it. Yeah, it just as awkward and awful as you thought that was very awkward and awful for me as well. My youngest two daughters, they are gorgeous little girls, very feisty, high energy. We had a lot of issues with them, and them being able to breastfeed. We struggled with breastfeeding. It turns out that both of them were tongue tied. I didn't know that until I was a bit too late in discovering a lot of these things. But they had a lot of upper respiratory things, chronically congested, always ear infection, throat infection, ear infection, throat infection, ear infection, throat infection. At some point, my husband and I could create just like a little guessing game and create a bet. What do you think it is this time? Probably a throat infection. Nah, I think it might be ear infection this time. Okay. And then we go to the pediatrician. The pediatrician tells us it's one of those two. And then boom, one of us was right, the other one was wrong. And we wound up with the same prescription, to the point where my husband at one point asked for a keg of amoxicillin as opposed to just coming back to the office again and again and again for the same prescription, right? Just give us the antibiotics, we'll be fine. So we struggled for a long time with all four of the children, but all of their issues, as varied as they were, because I seem to get like the run of things. I got like the full gamut, the full spectrum of all the things that it seems you can get with these airway disorders. Everything for them centered back to how they were breathing. Absolutely every single one of them. So, whether it was mouth breathing and the oral habits, or the poor sleep, or the upper respiratory infections, all of that was helped with some myofunctional therapy. And that was my pediatric dentist that I was working for at that time. And I am forever grateful. I still send people to that practice, even though I don't live in the state anymore. Like, I still will send people there. I'm forever grateful. And these are the type of relationships and long lasting impacts that you need to be creating in your practice, because so many people with all of these issues that you see here, it all stems back and around airway. And so having myofunctional therapy is a very selfish referral, because you are going to be helping so many people, but helping yourself more, because the impact is so great. It's so, so great. So, number two, we're winding down. We're heading our way to one. Myo is a commitment. I like this image of the cookie here where he's saying, eat me, because that's how I feel every time I see a cookie. But I really would like to lose weight. These two things, they don't go together really well. They really don't. But it's a commitment, just like you have to commit if you're going to make a lifestyle change. So I'm not going to say that word diet. That's a bad word. If you're going to make a lifestyle change and you want to lose weight and you want to commit to having a better, healthier lifestyle, you're going to have to make change that's long term. And with Myo, that's how it happens. So, unlike other things that you might refer out to or you might have in house where, the patient has a particular procedure done for them, like you refer to endo and the endodontist does all the work and the patient sits there, and all they have to do, the only commitment they have to make is to pay and to show up. That's it. Myofunctional therapy very much requires active participation. So I like to liken it to personal training, because it is the very best, most accountable analogy that you can make. So imagine if you go to a gym to work out with a personal trainer. You work out with a personal trainer one day a week. You go home, you sit on your couch for the rest of the week. You come back, you work out with the personal trainer again, and you repeat this cycle. Will you ever get six pack abs? No, no, ma'am. That is not how this person in the picture built their body. They did not. They had to commit. It was a daily process. It's them working to get that change in the muscles. And that's the only way that that happens, is with that commitment. So, myofunctional therapy works with muscles. They're just further up in the body. And just like the muscles of your arms don't work any different than muscles in your abs and your legs, the muscles of your neck and your head, they don't operate any differently. If you want change to happen in those muscles, you still have to put in a daily commitment of exercise and practice and patience. And so it happens over time. So don't please tell your patients that it's just a couple of exercises. It's just a little something that you can do. And then, don't worry, because you know what's going to happen? Number one, they're going to go YouTube. Okay. And Myo's not on YouTube. That's the number one thing dentistry needs to know about myofunctional therapy. It's definitely not on YouTube. Okay. Granted, everything is on YouTube. There are myofunctional therapy exercises on YouTube, but these videos are not the videos that are going to get them lifelong change. Okay. These are the videos that are going to get them like maybe a temporary improvement or maybe a little bit stronger with their tongue. Very rarely does habituation happen on YouTube. So imagine it just like the weight loss industry. We're going right back to that personal training. So I could go to a gym and I could work out with a personal trainer who would meet me, get to know me, hold me accountable, who would probably have me tracking my food, who would understand how my body works. My triceps are like trash and I need a lot more work on them than I do on other types of other muscles in my body and so forth. I can work with somebody who would be able to give me that one-on-one feedback, or I could go online, I can go on YouTube, and there are hundreds of fitness gurus and lots of different videos that I can go watch, and I can go and, try to lose some weight that way. Is that going to help me and my body specifically? Probably not, because you know what I'm not going to do? Those tricep exercises. I might do the exercises or the videos that I like, that are fun, that are easy enough for me, that don't challenge me, that don't push me. And I probably might not do anything else that I know needs to go along with it because I feel like I'm doing enough by doing the YouTube video, right? So just like you could easily YouTube how to fix my roof and you could patch your roof. I don't know that when a storm comes along, you're going to trust your patch. You might be worried and sit like, oh, I really hope that patch sticks because that was just like a YouTube video I watched. Maybe I should have called a roofer. That's the kind of energy that I want you to have behind myofunctional therapy. Don't go telling these people that it is just a couple of exercises and, it'll be fine. They'll just do this, that, and the next thing. Okay. So, just like how to stop cavities or how to stop decay or how to regrow enamel, these types of things. That is not on YouTube. Myofunctional therapy is not on YouTube. There's always alternatives because I think the YouTube reference comes out of two things. One, just not understanding how myofunctional therapy works. And two, out of, fear, price-based fear that people aren't going to be able to afford it. So there's always alternatives. Okay. There are some people who do hybrid types of therapy. I would highly encourage you, all of you, to talk to a local myofunctional therapist in your area or see what's going on. There are some therapists who offer sliding scales, reduced prices, payment plans, and like ways to make it work for the patients. Okay. So it doesn't have to be the same thing. With all myofunctional therapists, we're not all alike. Everybody kind of runs their business a little differently. You can also consult with other providers in your area and see what are all the options that are out there. But even more so, consider having in-house services, like having the myofunctional therapy in your office, providing it in your office. Because bonus tip that you need to know about myofunctional therapy, it definitely does produce. So I have a wonderful lecture, the Million Dollar Myo Day One Myofunctional Therapy Blueprint lecture that I can link to. For anybody who's interested, just put me in the comments and I'll link it. But we'll talk about Dr. Lee. And Dr. Lee is this wonderful dentist in New York who took on the Spur Dental Wellness plan and then resells the plan. So her patients get to see myofunctional therapists, as many patients as she wants, and she is benefiting greatly. She's actually estimated to make over $368,000 by the end of her year of Spur, just based on how she's going right now. So that's additional annual revenue that she has that has no additional work. Okay. So there's lots of different ways. There's actually no one particular way that you can have myofunctional therapy in your practice, in your life. There's so many different ways you can do it. You can kind of piecemeal it, break it down, make it smaller, make it easier to digest. You go full force, or you can outsource it. Whichever way you do, as long as you're starting to provide people the help that you know that they need, because at this point, you made it this far in the lecture, you know that they need this support, you're going to be golden, okay? So I really hope that when it comes to myofunctional therapy, you're so excited. I think that little meme is so cute, and I really wish StreamYard would allow me to like put in the videos, but I can't do videos on StreamYard. Otherwise, you'd hear him saying that because it's really cute. But more so than having a great idea, it's really important to implement. Okay. I love this quote by Wilbur Ross. So it's wonderful to learn about myofunctional therapy, to take these 5 things that I've taught you today about myofunctional therapy and the game changing impact it can have for your patients and your lives. It's even better to actually implement what it is that you've learned. So, I also did another lecture about how you can implement it and bring it into a practice. There's also a really great one about how you can educate. I'll be here live every single week, kind of going through again and again all these wonderful things, providing you a lot of great information that you can use to implement. But while we are here and we're talking, let's talk about the different options that you might be able to do because we talked about the various different ways. Okay. Um, Hands off. Spur Dental Wellness, a wonderful hands off method, just like Dr. Lee uses. It's Myo as a membership where your practice is a member of Spur Dentistry and Spur Dental Wellness, I should say. And then your patients, you can refer as many as possible. We don't charge them anything extra, it's covered by your membership. So it's like a value add of being a part of your practice where the patient gets to see a myofunctional therapist and they have one on one myofunctional coaching where they meet with the therapist every 1 to 2 months or so. And then there's no additional work outside of just the referral for that dental office. There's also a library of education for all the patients as well. So they learn why it is that you referred them. If you're looking to do myofunctional therapy as a part time thing, or you want to implement it in the dental practice in a way that is not so scary, it makes it more manageable. Myo Mind Shift, myomindShift.com. I don't know why every single time it gets cut off, this stinking slide, but it's myomindshift.com. So not just .c, .com. It's a 2-hour self-study lecture with a wonderful workbook and 5 programs that you can implement for myofunctional therapy that integrates seamlessly into any sort of practice and lifestyle. I've had a couple of different practices that have had like phenomenal success with being able to integrate without having to do the full totality of an entire program. Or you can go all the way with Myo Pathway. Myo Pathway is like my baby. It is the wonderful new higher standard of education in myofunctional therapy, where we've got 26 hours of education on all the basics, but then everything advanced. Because I get questions all the time about medical billing, cranial nerves, special cases. How do you deal with cases that are cosmetic in nature? How do you deal with this person that has Botox? How do you deal with this, that, and the other? How do you work with this appliance? You have all the answers to that. 26 hours of me talking and answering all of those questions and then more. And you have 6 months of weekly access to Q&As. So where you get a group Q&A structure where you're able to really sit down and take in all of the information. So it's live access to the instructor. That is longer than any other program has, period. And what no other program is doing, but I hope that in the future more will begin to do, is on-site mentorship. So it's really, really wonderful to learn and to get all of that information in here. But if you haven't learned what to do here and here, to actually get that into your practice with like a seamless system and you understand entirely what it is that you're doing, you're going to struggle. So 2 8-hour days, so 16 hours of on-site mentorship where yes, I come to you at no additional cost in the same price of the intro course is that visit where I'm there for 2 days and I'm able to see you do the work. That way, you know you're on the right track. You're doing your evaluations well. You're not missing anything. What could you have done better? Like I'm watching you in real time and able to help you establish a better way. So that's myopathway.com. If you are not already a part of the Myo community on Facebook, please join the Myo community on Facebook. I'll be here once a week, every week, with some more education for you. Next week, I think we're going to talk about screening and a great screening process for identifying oral facial myofunctional disorders and dysfunction in your current clinical roles. So if you have any questions, please put them in the chat. I'll be hitting all the different locations because I don't get to see the YouTube or LinkedIn comments, but I want to see all the different things and I'll be in the comments and I'll chat with each one of you afterwards. Thank you so much for joining me live today. I hope you have a fantastic day. Bye, guys.